All right, good afternoon, everyone. Thank you for joining. My name is Jana Simon. I'm the director of our Center for Policy and Partnership Initiatives here at the Illinois Public Health Institute, and we welcome you to today's training, Filing an Illinois Medicaid Claim for Diabetes Self-Management, Education, and Support Services, a how-to guide. And we're really excited to have you here. This is a follow-up training to the training we hosted a couple weeks ago about how to enroll in Medicaid for these services that are newly covered by Medicaid. And today is really about the billing and claims side. So with that, I just want to welcome you all and note that this training is being through a collaborative with the Illinois Public Health Institute with the Illinois Department of Public Health. And a lot of the information has been developed in collaboration with the Department of Healthcare and Family Services as well. As many of you may be aware from the last training, Medicaid now covers, as of August 1st, both the diabetes prevention program that is recognized by the Centers for Disease Control and Prevention, as well as ADA or ADCES accredited recognized diabetes self-management, education, and support services. So we're really excited that there's this newly covered benefit in Illinois, and we are here to provide some information on that. And the training is being supported in part by the Centers for Disease Control and Prevention. So we wanted to recognize our funders and our collaborators today. So at this point, I will go ahead and turn it over to our trainer, Lindsay Artola from Sage Health Strategy, to take us through the training. So Lindsay, I'll turn it over to you and stop my screen share. And as I think you all noted, this is being recorded. So we can send this out to you afterwards. Thank you.
There we go. Can everybody hear me?
Yes, thanks.
All good?
Yes.
Okay, well, good afternoon, everybody. Thanks for joining us today. As Jenna said, this is being recorded and we'll be taking questions in the chat box. I believe the IPHI team is monitoring the chat box. So please, as we go along, I've put some pauses in here throughout the training so we can take some questions as we go. So feel free to put them up in the chat box there. This is really focused, today's billing training is really focused on the DSMES program, the Diabetes Self-Management, Education, and Support Services. So that's where we are today. The next session we do will be billing for diabetes prevention program services. It's a little different, a little more complicated in terms of how you bill. So we decided we would separate them out so we could really spend some time on each particular program. It was supposed to be, I just wanted to make sure everybody knew it was supposed to be scheduled for next week. And unfortunately, I had something come up that I am not able to do that time anymore. So we've pushed it back a week to October 7th at 12:30 to 2. So if you'd already registered, it should automatically just move the meeting on your calendar. But just if you have other colleagues or providers that you work with, if you could just remind them that it is October 7th and they can register and learn all about billing for diabetes prevention services. So for today, we have a couple of things we're going to go over. I do want to just review with everybody the MCOs. I know there's probably a mix of folks in the group today, some that have already been working with the managed care organizations in Medicaid and others that haven't. So I just want to make sure everybody is starting from the same baseline knowledge of who the players are. And then we're going to spend just a little bit of time talking about Medicaid eligibility and enrollment. When we talk about billing, everyone is always thinking all that means is claims. But one of the first things that's going to be, whoops, I keep hitting my mouse and I'm going to move that so I don't move unexpectedly. It's not just about claims. It's really important at the very, very front end of providing services that you are checking your client's eligibility. And I'll talk a little bit about how to do that and why that's important. Then we'll get into the meat of the presentation, which is really how you're going to set yourself up to bill, how to file claims. And we'll finish off with just some common billing errors, some of the things that you should pay attention to on the front end. And then if you do run into some issues, how you can go ahead and fix them. So that's the agenda for today's training. So just a quick review. We did have some questions come up the last time because I know there are folks on the call who are very, very new to this. So the Department of Healthcare Family Services is the administrative body that regulates and runs the Medicaid program in Illinois, and they call the Medicaid Managed Care Program Health Choice Illinois. So you'll often see language around Health Choice Illinois, and that is basically Illinois speak for the Medicaid program here in the state. There are 5 managed care plans that the state contracts with to run the program. You'll see them here. We've got Aetna Better Health of Illinois, Blue Cross Community Health Plans, Molina Healthcare, Meridian Health, and County Care. County Care is the only one of those 5 that is not statewide. It only operates in Cook County. So if you are a provider that does not do business in Cook County, you probably won't have to get a contract with County Care or want to contract with County Care. Blue Cross, Aetna, Molina, and Meridian do operate in all 102 counties. So if you are outside the Cook County area, those are the 5 that you're going to be working with. And the last thing I want to mention, because we'll be referring to it quite a bit throughout the presentation today, is the Illinois Association of Medicaid Health Plans, which is the body that all the health plans belong to, has a comprehensive billing manual posted on their website. The link is here on the screen. And it is a soup to nuts kind of billing manual for how to successfully bill the managed care organization. So there's introductory chapters on just general claim submission information and the claim dispositions, rejections, denials, and how to deal with them. And then there's individual chapters for specific types of providers, as well as some appendices and resource and reference documents at the end. Now, right now, we've just issued the latest version. We have not yet written the chapter for DSMES or DPP, but it is in the works. So I would say before the end of October, you will see a new version come out with that new chapter added. So a lot of what I'm going over today will be included and can be referenced in the comprehensive billing manual. So I would definitely bookmark that link as you go along. It's going to be a really good resource for everybody. So let's start the day here with the Medicaid eligibility and MCO enrollment discussion. So I think it's really important for everyone to understand that the MCOs, the managed care organizations, do not determine who's eligible for Medicaid, and they do not enroll Medicaid recipients into the health plans. Medicaid eligibility, the determination of whether you qualify for Medicaid healthcare benefits, is jointly undertaken by the Healthcare and Family Services Department and the Department of Human Services. So the health plans have nothing to do with determining whether someone is eligible for Medicaid. And then in terms of Medicaid enrollment and how Medicaid recipients become a member of a particular MCO, that is done through a third party that HFS contracts with called Illinois Client Enrollment Services. The MCOs are prohibited from marketing or signing folks up to their own health plans. It's all done through a third party to make sure that recipients are getting consistent and objective criteria and can make a decision objectively about which MCO they would like to join. All MCOs offer the same Medicaid benefits. Every MCO has to offer all the Medicaid covered benefits, including the diabetes programs that we're talking about. Some of them, they'll vary by different add-ons or member incentive programs they may have. But just to let you guys know, the MCOs really have nothing to do with who's eligible and how they become part of a particular plan. And why is this important? Really important because one of the top reasons that claims get denied by MCOs is because a claim has been submitted and the member is not showing as eligible with that health plan. So either they are no longer eligible for Medicaid, they've lost their Medicaid coverage, or they are not with that particular plan. They have switched plans at some point. So what's really important is when you begin these programs and start providing services to Medicaid clients, you need to establish a really strong front-end registration process where you're checking either their member ID card. Every Medicaid health plan member gets an ID card. You can see some samples over there on the right-hand side. Or you can check the online Medicaid Medi system, which is the eligibility system that is online. And we'll talk about that in a sec. But it's really important that you check that eligibility each time you provide a service, because they can lose their eligibility in between, you know, the last time they saw you and this time. They could potentially have changed plans. So you really need to make sure that you're billing for a valid member and that you're billing the correct health plan. And it's document, document, document. Make sure that you have somewhere in the file that you took a copy of, you know, you checked their Medicaid eligibility and you had a copy of their card. And really make sure, you know, and even in some cases, we will say, you know, if you go onto the online Medi system, take a screenshot of what you're seeing there, so that if the health plan comes back and you say, I have a screenshot on, you know, September 23rd, when I provided this service, this is what the Medi system said. They're with your health plan and they were eligible on this date of service. So the best system, the Medi system, is the source of truth for both the health plans and for HFS in terms of eligibility and enrollment. So make sure that you have team members at your organization that have access to that system. It's open. It's an open online system. So you have to register to get authorization to use the system. And it's, you know, available 24 hours a day, 7 days a week. So, you know, depending if you offer evening services, it's not like a 9 to 5 kind of thing. It's an online 24/7 system. I've provided, we're not going to go into the details of how you sign up and register for Medi. It's a fairly simple process. You just have to get your Illinois digital ID, and it takes you through the process. So these are the links to register. The first link is how to register on Medi, and then they also have a Medi online manual. And it's just, as I said, a tool that you're going to want to build into your process to make sure that you are checking that your clients are eligible and enrolled with a Medicaid health plan. Any questions on, I've got to figure out how to move my picture here. Let's see if I can get rid of this. There we go. Any questions related to eligibility and the Medi system?
Nothing has come in through chat.
Okay, perfect. Well, then we will dive in to how to set up to bill. So let's just do a quick review because you can't start billing unless you are registered correctly in Impact. And I know we went over this on our last training, but you as an organization have to be registered in Impact with that specialty of DSMES using that taxonomy code for Health Educator. You have to get a new, I know there's been some questions come up since the last training. You do have to get a new NPI number. I know in the training we called out FQHCs, the federally qualified health centers, rural health clinics, but we have since had conversations with HFS and all providers. We've had a couple of hospitals ask that are providing the services. So no matter what kind of provider you are, whether you are a clinic, a hospital outpatient provider, a group practice, you will need to get a new NPI and do a new registration at Impact as a facility, agency, or organization. So I just wanted to make sure that we clarified that for the hospital, outpatient providers, and other group practices that might be providing these services. So you can't file a claim unless you are registered and have your Impact Medicaid ID number. You cannot bill for services if the member isn't eligible. So these are the criteria for eligibility for these services. By the member, they have to be between 18 and 64 with a documented diagnosis of either type 1, type 2, or gestational diabetes. And then, of course, the diagnosis criteria in terms of fasting glucose, et cetera, et cetera. So you have to make sure that your member that you're providing services is eligible. And here's what's really important. And if I had a highlighting pen, I would highlight this. You cannot submit a claim and a participant can't receive services unless they have a referral from their treating practitioner, whether that's a physician, an advanced practice nurse, or a PA. They have to have a referral. And that referral has to come from a practitioner who is also registered in the impact system. That referring provider also has to be a Medicaid registered provider. This is a federal rule called the Ordering, Referring, and Providing Rule, or prescribing, sorry, Ordering, Referring, and Prescribing Physician Rule. So it's really, and we'll talk a little bit more about how you determine whether a referring provider is registered in impact a little later, but that's really important. They require, unlike the DPP program, DSMES participants must have that referral, and it must be from a provider who's also registered in the impact system. Not as a DSMES provider, just registered as a Medicaid provider. So there's 3 options for filing claims. You can file it as a paper claim. You can use electronic submission through a clearinghouse called the 837P format. Some of you, like our hospital providers or our encounter clinic providers that are already billing Medicaid, are likely filing claims electronically. And then most of the MCOs also allow you to submit claims through their portal. They all have provider portals. And you can key in a claim directly into the portal as well. How you as an organization decide to file claims really will vary. You know, if you're going to be doing a lot of claims, you probably do want to think about doing an electronic submission. But if you don't think you're going to be filing, you know, a huge volume, maybe paper claims or portal submission is just fine. Obviously, if you're filing electronically, you do have to have certain revenue cycle clearinghouse capabilities. And then also check your contract language with the MCO, especially if you're, again, a hospital provider or a clinic provider that already has a contract. Sometimes the contract will dictate how you have to submit claims. The MCOs prefer electronic submission. It goes faster, it's much more automated, and you tend to get paid faster because it's an automated system. But again, if you're a smaller organization, community-based organization, and you're not really set up to do medical billing, paper claims are just fine, or submission through the MCO portal is also fine. So you can, you know, have that discussion internally, what makes the most sense based on your setup. So if you are going to make the decision to file claims on paper, you have to use these are just some quick do's and don'ts. And I'm not going to read them all, but just to highlight some that are really important. You have to use the original billing form. It's a standard national form called the CMS 1500. It's red and white. I'm going to show you an example a little later, but you have to use the original form. You have to order them and use that form. You can't use a photocopy or any kind of, you know, facsimile that you pulled off the internet. You have to order the actual forms. And you have to use either, you know, a PDF filler arrangement on your computer or type it out. You can't handwrite the form. So just make sure that you're using it, you know, either a word processor or typing it out on a typewriter, whatever works for your organization. Just don't handwrite it. Don't use any kind of staples or colored ink or any kind of extraneous information. It is a paper claim form, but it does get run through an automated reader. So you don't want to put anything that's extraneous or, make sure you're staying within the boxes, because it does get scanned through a system. So those are just some of the do's and don'ts, basic do's and don'ts of filing a paper claim. Now, again, some of you are probably already filing electronic claims. There's sort of some key steps involved first. And if you're considering moving into an electronic claim submission, these are sort of the key steps to keep in mind. You have to have a clearinghouse that you work with. These are large organizations that filter all the claims before they go to the managed care organization. So you're going to have to select the clearinghouse that you want to use. And you're going to get in touch with them, let them know that you're submitting claims to whichever MCOs you're going to submit them. The clearinghouse is going to talk to you about what data records they're going to need to submit the claims. And you're going to start filing them through the clearinghouse. You're going to get 2 reports from the clearinghouse. So you're submitting your claims through the clearinghouse with all the data elements that we're going to talk about. And then they're going to screen them. They do a first pass screen to make sure that those key data elements are there before they send them on to the MCO to be processed. So they're going to do this first screen, and then claims, if they pass the screen, will go to the MCO. And sometimes some MCOs will then do a second screen to look for those key data elements. An additional, they may have a few more data elements they're looking for before they'll accept that claim into their system to be reviewed and paid. So you're going to get a report every time you file claims through the clearinghouse. The first report you're going to get is going to show you what claims that you submitted were accepted and passed through that screen and were transmitted to the MCO. And the second report are going to show claims that went through that first screen at the clearinghouse, but they were rejected by the MCO for some reason. They didn't pass through that second report, or that second screening, sorry, at the MCO level. So it's really important that you review those reports and see which of my claims didn't pass through that screen, which of them were rejected by the clearinghouse, and which of them were rejected at the MCO level, so that I can make those corrections, edit the data, make sure that I fill in the field that they said is missing, and then you just resubmit them. So it's really important you do that on a daily basis. We often find that people don't do that, and then they can't figure out why our claim hasn't been paid, and they contact the MCO, and the MCO says, well, we don't have a record of that claim. And it's because it was rejected right at the front end. It never made it into the MCO's claim system. So it's important that you review those reports, see which claims were rejected, make the corrections, fill in the fields, take out the punctuation mark they didn't like, and resubmit them into the clearinghouse. So that's the electronic data submission. Once they get past those screens, they get put into the MCO claim systems, and they begin to get adjudicated and paid. That's electronic claim submission. And then, as I mentioned, a third option is doing straight submission through the provider portals. I would recommend, regardless of how you decide to submit claims, register on the provider portal. We'll talk a little bit, there's a chart at the end that shows the functionality of these portals. Great way to keep track of your claims, no matter how you submit them. So these are the portals, you can all sign up for them. And they do have, with the exception of county care, they do have the ability to submit and key in your claims directly into the portal. So again, highly recommend registering for the portals. And if you're not going to be doing a lot of claim submission, you may want to take a look at just doing direct key entry of your claims through the portal. So I'm going to talk a little bit about how you complete, look in more detail at the claim element. But before I do that, I just wanted to pause because I see some numbers, some chats coming in. Is there anything I can answer now, Rebecca or Jana?
Yeah, we have a couple of questions that have come in. The first one is, does the treating provider need to be the provider managing the patient's DM, or can it be a MD/NP referring R/T hospitalization or other specialist?
It can be whoever is treating the client and feels that they would benefit from the DSMES system. So it doesn't have to be their PCP. They could have been at an ER, and whoever is making that referral, the key thing is they have to be a Medicaid registered provider. So they have to be in the impact system.
All right, and we typically bill on a UB, not 1,500. How does this change?
Here's my hospital friends. You will not be able to bill these services on a UB. So you will have to fill them, you will have to submit them on a CMS 1,500 because they are not because of the way you're registering in impact. And again, this is something we need to clarify and get a little more clarity from HFS on, but right now it is on the 1,500. It's not a facility inpatient services, which is what the UB is for. Because of the way HFS set this up, you'll have to use the 1,500. And we can have a conversation offline for the hospital folks if that's super problematic. We may need to have another discussion with HFS. But most hospitals, will have some professional services that they're billing on the 1,500, so it shouldn't be, hopefully, too problematic.
That seems to be it for now.
Okay. All right, so I'm gonna now.
More just came through.
Yep. So as a FQHC, you stated that we have to apply for a new NPI number.
Yep.
And then yes, I would like to have a conversation after so I can get some clarifications as I'm getting flack from finance about this.
I wish I could help. No, it's similar if you're an FQ and you provide substance use disorder services. You have to get a separate NPI to bill for those services. It's the same with these services. They're not part of your encounter rate. They are billed and paid separately from an encounter rate. And HFS is requiring providers to have a new type 2 NPI and a new impact registration, just like FQs or encounter rate clinics would do for substance use services. But I'm happy to, we're happy to chat after.
There's another question. Does a health educator have to be a certified educator? And I can answer this one, Lindsay, if you want.
I was gonna say, I think that's a Jana question.
So to be accredited by ADCES or recognized by ADA, somebody on the DSMES team has to be certified to meet the criteria set forth to get those accreditations and recognitions. For purposes of billing Medicaid, anyone on the DSMES team can provide the service because you're only billing it at the organization level. You're not billing it based on who's providing the service. So as long as someone on your team that's included in your accreditation or recognition process as part of your team, as long as they're the ones providing the service and you have your recognition, you're just billing as an organization. You are not listing individual providers. So you do not need to have all your DSMES team be certified health educators because you're not listing out who's providing the services.
Perfect. Okay, so we're gonna,
Sorry, one more, Lindsay.
nope, go ahead.
If you are part of a hospital, do you still have to apply for a new MPI number?
Yes, you do. And we had that question come up from a couple of hospital providers, and we double checked with HFS, and the answer was yes. All new providers will need a new MPI.
And it partly has to do with the fact that you need to have the new provider types. You need to have the MPI linked to the new provider types they've created for these services and the taxonomy code for the health educator. So because all those things have to link up, it needs to be under a new MPI.
Exactly. Yeah, just the way the logic and the impact system works.
Another question has come in. Any idea on reimbursement expected? Are these billed in the same increments and for Medicare?
Well, that's what we're going to get into now. Jill and Jana might be able to answer the Medicare thing, but we are going to talk about the reimbursement. So
it is very similar.
On that one.
Yeah, it is very similar.
The increments are the same. I just don't know about the reimbursement rate. It's usually not as good as Medicare, but.
No, it's slightly better than Medicare and allows for a lot more number of increments. So there's a lot more units allowable under Medicaid than there are in Medicare.
Yep.
So go ahead, Lindsay.
One more question came in, I'm sorry. The new NPI number for the hospital or the DSMES provider?
So the actual DSMES provider, if you're meaning the individual who's providing the services, they do not need an NPI. Again, as Jana said, these services are only billed at the organizational level. So the individual practitioners providing the services do not need to be registered in Impact or have a new NPI. Everything is done at the organizational level. So it's just the organization that needs the new NPI, if that's what the participant's asking.
One more, and I think everyone will start to understand the rhythm to the responses, but an FQHC already bills some service under a separate fee-for-service MPI. Can we bill under this MPI?
No, you cannot. I wish. No, because of the way, again, the logic is set up in the impact registration system. If you went in and tried to add this provider type or this taxonomy code to that MPI, it wouldn't allow you to do that. It has to have its own MPI, its own specialty and subspecialty and taxonomy code all linked together.
The main answer when we talk to HFS is everybody needs a new MPI to bill for these services.
Yep. And don't shoot the messenger.
It looks like we can move on now, Lindsay.
Okay. So I'm going to run us through how you complete the CMS 1500 form. I'm showing the paper form. I'm going to walk through it in the paper form, but all the fields and what you need to fill out would apply in the electronic format or if you were doing it directly into the portal. So I'm just using the CMS 1500 form to illustrate, and it's easy to see the different fields. But again, the information that goes in each field is going to be similar no matter how you submit. So for those of you that do decide to start submitting claims with the paper form, this is the CMS 1500. You can see the red and white. There is a step-by-step manual. I've put the link here that talks about each individual field. All the fields are numbered. We'll go through each field and give you the information of what goes in that field. Some fields you will not need to fill out. And you'll see when I pull up the form in more magnified view, some of them will not make sense to fill out. And as it relates to the referring provider, and remember, they have to be registered in Impact, HFS provides a lookup tool. This is the link. If you click on that link, you can look up the provider when you get the referral, either by their NPI number or their name. There's different ways to do a search, and you will be able to see whether they are registered in Impact or not. So that's another link that you're going to want to bookmark because you're going to want to validate before you submit a claim that that referring provider is in impact, or your claim will be denied. Oops, why is it not letting me? There we go. Okay, so all claims, these are the basics. This is one of those, when I talked about that first screen that the clearinghouse would go through, these are some of the things it's going to be looking for, just some absolute bare basic minimums. You're going to have to identify the name and your tax ID number of the organization, of your organization that provides the service, with that matching NPI number and taxonomy code based on your impact registration. So what Jana was saying, everything has to tie. The name of your organization, your tax ID number, that new NPI number, and the taxonomy code all have to match, and they have to be on that claim form. You have to identify the name of the patient, their RIN number, which is their Medicaid ID number, their recipient ID number, their address, and their date of birth. You have to list the date of the service that was provided, and you have to identify where the service was provided. Every claim has to have a diagnosis code, a procedure code, which we would call HCPCS codes. If there is a modifier that's required, which we'll talk about, if you're doing telehealth visits, the modifier will be very important. And again, that place of service, and we'll talk about place of service codes as well. This one is not as important, but Medicaid is always going to be the payer of last resort. So if there's workers' comp, I don't know that there would be in a diabetes situation, but there's any other kind of insurance coverage that this individual may have, those insurance resources, those third-party payers have to be billed before Medicaid. I don't think it's going to apply in that many cases, if at all, in this instance. And every claim has to be signed and certified by the provider that the information is valid and the service was provided. Okay, so those are just the very bare minimum basics to get through that first screen. As it relates to DSMES, there are some other key claim elements. Here are the diagnosis codes that have to be included on the claim, and I will be showing you a claim example so we can walk through these on the claim, but these are the 3 diagnosis codes. If you're working with a diabetic population, they're probably very familiar. You'll probably have like an E10 point, I don't know, I'm not a clinician, but I don't know if it's 9 as, diabetes, no complications. So you will probably have some extra digits, but at bare minimum, you have to have one of these diagnoses on the claim to show that the member is eligible for this service. Over on the right, you'll see field 24B. That's your place of service code. Every claim will have to have a place of service code that shows where the service was provided. And these are the only codes that will be accepted for this service. So it's either delivered as a telehealth visit, it was delivered at a school, a homeless shelter, an office setting, in a home setting, an assisted living facility, or a group home. And then we have this other. So I know there's some folks that maybe set up in a local library or the local community center. That's when you would use the 99 place of service. For our hospital-based programs, we did have that conversation with HFS because there are obviously place of service codes specific to hospital outpatient settings, whether they're on-site or off-site. And HFS said they were going to look further into that, but for now, if you are a hospital-based outpatient program, you will use place of service 11, an office setting, unless of course you are, happen to be doing it in a school or via telehealth, in which case you would use the appropriate, either O2. If you are doing your visits, and of course, in the environment we're in now, a lot of visits will be going through telehealth. You have to use that place of service code 02. But when you fill out your claim form and you put in your procedure code, you have to put in that GT modifier, and that just indicates on the claim that it was a telehealth visit. And I'll show you again on the claim form where that goes. So it's really, that's the only one where you're going to put the GT. You will have to put that GT modifier when you provide these visits, either through, you know, video or telehealth or online. And then we have the last one I wanted to show you is field 24D. These are your procedure codes. So it has to be, you know, one of these two codes, either an individual session was provided or a group session was provided. Here's the attached HCPC code that you're going to use. Here's where we're getting into the units and the payment question. Each unit, so you're going to bill by unit. It's 30 minutes. Your payment is $55 per unit. And in a 12-month period, no individual can have more than 6 units of that particular service. So that equates to 3 hours. And then you'll see, you know, similarly on the group side, it's a different code indicating that it was a group service, same unit, 30 minutes. The payment's less because it's a group versus an individual. And there's a maximum of 30 units or 15 hours in any 12-month period. Any questions on those before I move over and show you the actual CMS 1500 filled out?
Yeah, we had one question. Well, I guess 2 now come in. We are a FQHC. We have 4 different NPIs for 4 different locations under the same tax ID. Do we need to apply for new 4 NPIs if we happen to provide DMES services at all 4 locations?
So what I'm thinking is when you bill for your encounter, I gotta think through this just a sec. But they're all under the same, do they all have, I'm sorry, do they have all different tax ID numbers too?
No, the same tax ID number with 4 different NPIs.
Yeah, no, I think what you will do is you'll just have one, because you'll have a billing provider, just like when you bill now for your encounter rate, you probably have a billing provider that's your main administrative location. And that would be the one you would get the NPI for, and where the service is provided, you can just put that as a service facility, but you don't need to. We'll look at, when I look at the claim form, I can show you how that works, but you don't need an individual NPI for this specific service. You're just billing under that main NPI.
So it would be one NPI for all 4 locations for these services.
Yeah, because I think right now what happens probably, again, I'd have to talk to the individual offline, but I'm assuming that right now when you bill for your encounter, it's all being billed by the same administrative location where all your checks, all your payments are going to that main NPI number. And then the individual facilities are just considered rendering providers. We just don't use rendering providers in this particular instance. But we may need to just chat offline so it doesn't get too confusing.
Great. Next question is, will there be a portal to look up hours used or available when verifying eligibility?
No, that is not something we could look up. Jill, I'm trying to think how, because I do that sometimes with DME. You probably would need to talk to the actual MCO.
Yeah, that's one of those outstanding issues that we still need to resolve in terms of when someone switches MCOs in the middle of a cycle. But just to be sure, if someone has already started a cycle, you would definitely want to verify with the current MCO.
Someone else asked, is the 12 months rolling or January to December?
I think it's rolling, right, Jill?
That was the intent, yes.
Yeah, so if you start your
12 months from their first, it would be 12 months from their first claim or first date of service.
Mm-hmm.
Another question is, will there be a reimbursement for MNT coming in the future?
A reimbursement for what? Sorry, I didn't hear that, Rebecca.
MNT?
I'm not sure what that means.
Yeah.
Yeah, I'm not sure what that is.
I don't think we can speak for HFS on that. Oh, medical nutrition therapy.
Oh, I can't speak to that.
Yeah, we don't know. And someone asked if we can revisit the MPI rule one more time.
Yeah, so every provider of this, if you want to be a DSMES provider or a DPP, but in this case, DSMES, even if you're already registered in Impact and have, you know, an NPI, you have to get a new NPI and start a new Impact registration as a DSMES provider. You can't go in and edit your current Impact registration and just add this as a provider type. It won't be an option. HFS wants this to be a clear, clean, here's your NPI for diabetes programs, here's your provider type, here's that taxonomy code. So whether you're an FQHC, a group practice, a hospital outpatient program, you have to get a new NPI and start a new registration. When you go into Impact, it's not going to be edit or amend, it's going to be new Impact registration. You're going to register as a facility agency organization enrollment type, FAO. The specialty is diabetes, self-management, education support services, no subspecialty, and then the taxonomy code 174H, I don't know, 4 or 5 zeros and an X for health educator.
And Lindsay, if someone wants to provide both DPP and DSMES, can they do that under one MPI and register as both subspecialties at the same time? Not as both specialties at the same time?
Yes, I think you can do that, yeah.
Yeah, so you can get one MPI for if you're doing both DPP and DSMES, one MPI for those two things together and you register together.
Yeah.
And more questions have come in. So Rebecca, do you want to read them?
Sure. I think this might be related to NPI number as well, the RHC as well. If they need a new NPI number for RHC, I believe that's what they're referring to, that question.
Yes, that's a rural health clinic. So yeah,
okay.
Same.
Great.
Doesn't matter what provider type, where you are, what you do, you're going to have to get a new NPI.
And is the benefit once in a lifetime or annual refresher allowed?
It's per 12 months, so there's no lifetime cap.
And as an FQHC, do we use POS 11 or POS 50 when billing for the services if it's a face-to-face visit?
You would use 11. 50 would not be allowed. Because this is not an encounter rate service, it's a fee for service. So you would use 11.
I think we're done for now.
Okay. So let me switch screens here for a sec so I can show you. Let me see if I can do this. It worked when here we are. All right, are you seeing my CMS 1500?
Yep.
Okay, so here's the form, and I sort of did a mock form for y'all. So here's the first, you'll see all the different fields, they all have numbers. Obviously this one, you're gonna hit the Medicaid box. Insured's ID number is gonna be the Medicaid ID number that shows up on their card. That's their RIN, recipient ID number. You're going to put, obviously, patient last name, first name, their date of birth. Follow the, it's very important that you follow the format that they request. So you're going to do month, date, year, female or male, obviously. And then I've already found 2 mistakes on my form, guys. I apologize. This, I just realized, should be 65, not 1965. I will correct that before we send these out. You just want the last 2 years. So you don't want the 19 in there. You want the patient's address. You do not want any punctuation. So you don't want commas, you don't want periods, no punctuation. Same for the phone number. It only will allow for 10 digits. So you're not going to put the dash in between the numbers. This one you actually don't need to fill out. It's going to be the same insured. That's more on a commercial side, but so I will also take that out so you see that you don't need to fill that piece out. And then, you know, is the patient's conditions related to employment, auto accident, other accident? Those are all going to be no. You do need to fill that out. Other insured's name, you know, all of 9 is not going to be anything that you need to fill out because this is a Medicaid claim, so there's only one insured. Insured date of birth, you know, again, you can put it in if you want. It's probably, I shouldn't say probably, it is optional. And then this is where you're going to put the MCO's name. So it's going to be Aetna Better Health, County Care, Meridian Health, whatever the MCO is where you're submitting the claim. Is there another health benefit plan? If this is straight up Medicaid, you know, you're always going to put no because, you know, these are 99.9% of the time going to be just straight up Medicaid. So you're just going to put no in there. This is the key piece here, and that's why I highlighted it. Box 17 is where you're going to put the referring provider's name and their NPI number. So you're going to want to put, you know, their name and their credential, no punctuation, their NPI number. In terms of the box 14, the date, sorry, why is that box there? The date of current illness, injury, or pregnancy. You can just put the date that the referral came in, the month, date, year. None of these, hospitalization, unable to work, none of these are applicable. You do not need to fill them in. You will not need a prior authorization number. These are not services that require any kind of prior authorization from the plan. You just need that referring provider. Box 21 is your diagnosis code. You'll see here it says ICD indicator. You're going to want to put a 0 there. That indicates that it's ICD-10 that you're using, not ICD-9. We've made the conversion over to ICD-10, gosh, probably 3 or 4 years ago now, maybe not quite that long. So just put a 0 there, and then you're going to put your diagnosis code. Boxes 24, all the different lettered 24 boxes are related to the actual service. So you're going to put the date of service. So this, in this case, it's, you know, September 26th, 2021. Here's where you're going to put your place of service code, you know, whether it was telehealth, an office visit, in an assisted living facility. In this case, we're putting O2, it was a televisit. Here's that procedure code. This is an individual session, G0108. And here's where that modifier goes. Remember that asterisk. If you do a televisit, you have to have this modifier. So you're going to put that GT modifier. If this was an office visit and you had place of service 11 in there, no modifier is needed. Only the modifier is only needed when you're doing a telehealth visit. So that can be blank unless it's telehealth. Diagnosis pointer, this is really more important when you have multiple procedures or pick codes. But it basically is just wanting to know, you did this procedure, what diagnosis code that you listed relates to this procedure? And you really only have one diagnosis code, but just put A in there. You're going to put the charges, $55 a visit, or a unit, sorry, and you did 1 unit of service. If you had done a full hour, you would put 2 units, and that would become $110. This is where we get into that question that the FQHC, you do not need to put rendering provider. People have been asking about, the individual educators, et cetera. It's all done and all billed at the, whoops, I'm going the wrong way. It's all billed at the organizational level. You do not need to put, Davy Smith did the education session. This does not need to be filled out at all. You don't need an individual NPI or educator's name or taxonomy in there. You can just leave that blank. These are also very important fields. Field 25 is your organizational tax ID number. Just indicate that it's a tax ID, not a social security. This is your account number. So this would be your internal number to follow that patient account. Always hit yes for accept assignment. Your total charges. You're going to, I can't seem to, let's see if I can make this fill up. Got a box in my way. I don't know if you have the same problem. You're going to have your signature and date of the organization. So whoever maybe signs your checks or whoever it has signatory rights at your organization needs to sign it, certify. And then your billing provider. So this is your organization name. So it's Main Street FQHC, it's, main, small town hospital, outpatient clinic with the address and phone number. Again, no punctuation in the address or it won't get read properly. And then, gosh, I can't get rid of this box. 33A is going to be your NPI number. And 33B is where you're going to put your taxonomy code. So 33A is your NPI number. 33B is going to be the taxonomy code, that 174H. You preface it with a ZZ. That's just an indicator. There's different types of numbers that can go in there. ZZ indicates that it's a taxonomy code. So preface it with ZZ and put that taxonomy code. If your box 25, which is your tax ID number, box 33A and 33B do not match what is in impact, your claim will deny. So it's really important. 25 is your tax ID number. 33A is your NPI number. 33B is the taxonomy code. Any questions while I've got the form up before we go back to the presentation?
Yeah, so a couple of questions. Is period in diagnosis acceptable?
Yes, that is acceptable because diagnosis codes can have a number of different digits after this. They can have up to 5 different digits. ICD-10 is very, very specific in the diagnosis code. So you could have just E10, but most of the time for diagnosis codes, there's going to be, digits after that period. It's just another. So this E10 is just type 1 diabetes, I think. 0.9 indicates it's no complications. You could have 0.8 that means Again, I'm not a diagnosis person. I don't know all the ICD-10. I'm not a medical coder, but that is acceptable if you're going to have a more specific diagnosis code.
Great. If someone fills in the rendering provider, wait, 1 second, I can't see the question. I'm sorry. If someone fills in the rendering provider field, will the claim get rejected, or is that part just ignored since it's not needed?
Yeah, most claim systems will just ignore it. Unless they're looking for, there's some certain claims that, you have to have a rendering provider. And so the MCO system is, programmed to look for it. In this case, they will just ignore whatever is in there.
So no rendering provider is listed, only the referring?
You have to have the referring. They will absolutely be looking for that with an MPI that's registered in Impact. And you have to have your billing organization provider in box 33 down here. You have to have that with the appropriate NPI, taxonomy, and tax ID. So those are the key elements. The MCO system is configured to ensure that Susie Smith is there with her correct NPI and that they are in Impact. It's going to be looking for the billing provider. See how it says billing provider, the tax ID, the NPI, and the taxonomy code to all match.
And if the referring provider is not the one signing the form, who is signing it?
It would be a whoever it has signatory authority for your. It doesn't have to be a clinician in this case because it's a billing provider. So it could be whoever has, within your policies and procedures has the ability to sign claims.
Great, that seems to be it for now.
Okie doke. Let me get rid of this and go back to this. If I can find it, where is my, oh, I lost my, oh, there it is, sorry. Apologies, I couldn't find my screen. Okay, so this again, biggest thing is, make sure that you're putting in that referring provider. Here again is that lookup tool. So you can look up Susie Smith gave me this ID, this NPI number. Let me go look her up and make sure she's in Impact. And as I said, I will make the corrections because I did just notice I did the 1965 wrong there. So I want to make sure I get that corrected before I send it out to all of you guys. So that's how you fill out. And again, whether you're doing it on the portal or within an electronic format, those are still the key claim elements that are going to be included or need to be included on your claim. Now it won't let me advance the slide. There we go. All right, one last thing on claim submission. All the MCOs have a timely filing requirement that you must submit your claims within 180 days from the date you provided that service. It's the same for all the MCOs. You have 180 days from the day you provide the service. And that requirement applies to both that initial claim that you may send, but then also any corrected claims. So if you submit a claim and it gets rejected, or you submit a claim and it's accepted into the MCO system, but then it's denied for some reason, it doesn't, and you want to submit a corrected claim, make a change, it still has to fall within that 180-day window. So it's really important that you never hold claims, that you try and get those claims out as quickly as possible. So if anything goes wrong with that claim, whether it's a rejection or some sort of denial, you have a lot of time and a lot of runway to make those adjustments, those corrections, and get the claim back in to get paid. So so the mantra for all providers, no matter what type of provider you are, never hold your claims, get them out the door, and give yourself as much time as possible to make any corrections that may come up. Hopefully you won't even have to, but the sooner they get out, the sooner they get paid. So that's it on the sort of how you submit a claim. And then I'm just gonna we have until 2, Jana, is that correct?
Yeah, that's correct.
All right, so I'm gonna just quickly move into when things do go wrong, how to correct them. So there are some common billing errors. I just wanna get everyone's heads and eyes on them. So there's 2 things that can happen with a claim. Well, actually 3. One can be they're adjudicated and paid, which is what we're all hoping for. And I would say the vast majority of the time, that's how things roll. But you can get rejected claims and you can get denied claims. And I just want to make sure that y'all know how to respond if that should happen. I'm going to skip this one. So claim rejection, again, if you recall from earlier, is when it doesn't pass through that initial screen. There's some missing fields. Maybe there's a punctuation piece in there that's spitting the claim back out. It can happen at the clearinghouse level, or it can pass through the clearinghouse, but then not make it through that second screen at the MCO and it gets spit back out. If you have claims rejected, you will know that they're rejected because it's the clearinghouse that notifies you, not the MCO. The MCO doesn't even know that claim exists yet. It's the clearinghouse that is going to notify you. A claim denial is when that claim has made it into the MCO system and they've begun the adjudication and the processing of the claim, but they have found something wrong with the claim. It's not matching up and you're going to get a denial. And when that happens, you're going to be notified by the MCO. So that's how you know if it's a rejection or a denial. Denial will come from the MCO and they have a record of the claim in their system. Rejection is going to come from the clearinghouse. The MCO has not got that claim in their system. They have no idea that claim even exists yet. I'm going to pass through this. So claim rejections. These are the most common reasons claims will be rejected. Again, it's those basic elements. Member not eligible is the #1 reason. Diagnosis codes might be missing. Member date of birth might be missing, or inputted incorrectly. A modifier might be missing. So these are the most common reasons that claims will be rejected. When you get a rejection from a claim, just verify what you've submitted, go through each of those fields, make sure everything is correct. You can verify with your clearinghouse to make sure that what you sent is what they received. Sometimes there's a glitch within the data systems. But the most important thing is make that correction, fix those fields, add that data, edit that data, and resubmit the claim. This is still a new claim, not the same. It's considered a new claim because again, the MCO has never received it. So you just want to find out what was wrong with the claim, fix it, and resubmit it. So again, a denial is when the claim's been accepted, all the appropriate fields are there, but it is being denied for some other reason. And in this case, I think ORP, the lack of a referring physician, the tax ID number isn't matching, the NPI isn't matching the taxonomy code. You are going to get an explanation of payment, an EOP, or a remittance is another way it's described, from the MCO that's going to list the claim number and identify why it was denied. These again are the most common reasons for denial. Place of service code is invalid. So our hospital friends don't put, hospital outpatient number 22 or 23, I can't remember what it is offhand. That will be invalid because for this particular procedure code, only those place of service codes that we showed you are valid. Member not enrolled on that date of service. So again, make sure you're checking your members or your clients on the front end that they are enrolled and eligible when you provided the service. provider TN and NPI do not match, make sure you're using your diabetes NPI and not your, FQHC or your hospital NPI. You've got to make sure all of the tax ID number, the NPI number, and the taxonomy code are on that claim form the way that they are on your HFS impact enrollment. Again, so you'll get these explanation of payments. The claim has gone into the MCO. They're going to send you an explanation of payment. It's going to show you which claims they had, which were paid, and what were they paid at. And then they're going to also show you which claims were denied, and they're going to give you a reason that that claim was denied. And they're a standard set of remark or adjustment codes, and you'll see them on the actual claim denial or the, explanation of payment. This is just an example of one. You'll see there's the date of service, there was the procedure code, and then there's a comment code here at the bottom, 45 CO, I can't see that, charges exceed, what they should. So you somehow put the wrong billed amount in there. So it's going to be very clear on what's wrong with the claim, and then you just have to go in and fix it. Some explanations of payment are a little easier to read than others, I'll be honest. But in the billing guide, which I showed you, in the billing guide, Appendix E has each of the plan's EOPs with, you'll see like a key. So you see A, B, C, D. It tells you what each of those things mean. So if you get an EOP from Aetna Better Health and you're like, I have no idea what this column heading means, just go to that billing guide and the educational EOP, and it'll walk you through what each of those columns and each of those terms mean. So you can sort of decode the EOP if you ever have any problems with it. So the rejection, you just file that new claim, you fix it, you resubmit a new claim. If you get a denial, you have to submit a corrected or a replacement claim. And that's a replacement of a previously submitted and adjudicated claim. So it's come into the MCO, they've adjudicated it, they've denied it, they found something wrong with it, and they've said, you have to fix this if you want us to re-adjudicate and pay this claim. And again, whether you're submitting a new claim because it was rejected, or you're submitting a corrected or replacement claim, you have 180 days from that date of service to complete all of this. So again, that timely filing is really, really important. So if you get a denial, you get that EOP and you want to correct it and send in a corrected claim, what the MCO, and this is what confuses a lot of people, is they'll delete, what they do is when they get that replacement claim, they delete out the original claim completely and replace it with the corrected claim. And what they'll do is they'll debit. So if your original claim was for $100 and they only paid you $80, they're not going, and you submit the new claim to say, no, you actually owe me $100, and here's why, and here's all the correct information now. They don't just pay you that $20 that was missing. They're going to take back the $80 because that claim is no longer valid. It's been voided out. So they're taking back that $80, and they're going to pay that new claim for $100. So I just mention that because it does sometimes confuse people when they see their explanation of payments and they're trying to track their revenue and claims payments. So remember, if you're submitting, keep track of any corrected claims that you send in, because that original claim is going to be voided out. You're going to see it as money being taken away. But it's just that they've voided out that claim. They're taking that money back so they can pay you correctly with the corrected claim. And again, there's instructions on how to submit a corrected claim and how MCOs accept them in the comprehensive billing manual. So when you submit a corrected claim, again, the EOP or the remittance is going to tell you what was wrong with it. So you just have to go back to that claim, fill out a new claim with the corrections on it, make those changes, and you'll see this is a snapshot of the CMS 1500. This is box 22, which we left blank on our original claim because it was just a new claim. You'll see it says, it's not really clear, but it's resubmission code. So this is indicating on that claim that you're resubmitting the claim, the original claim number. So you're going to have the claim number on your EOP. You're going to put that claim number in here in box 22. Everything else on the claim is going to be what you submitted before with the corrections made, but you're telling the MCO, I am replacing that original claim with this new claim. And that's how they know it's a corrected claim and they'll adjudicate it. I know it's clear as mud, but if you do run into denials, I want to make sure y'all know that there is a way to correct them and still get paid. The most important thing to remember is you only have 180 days to send in that original claim. The MCO has to process it. It's going to take them some time to adjudicate it and get you that remittance advice. And then you only have, then you're going to want to turn around real quick and submit your corrected claim. So, get on those portals, follow what's going on. Here's what I wanted to mention about the portals in terms of managing your revenue cycle. All of the portals have a lot of functionality that you want to take advantage of. You can look up members and verify that they are eligible for service. You can, again, submit claims online. You can submit corrected and replacement claims online. And it will show you whether your claims have been received, where they are in the process. Are they, have they been denied? Have they been paid? And you can also see, again, not across the board, Blue Cross does not have some of this functionality, but you can see if it was showing as denied, you can see why wasn't it? And it'll show you those remarks or reason codes so that you can start looking at resubmitting those corrected claims. So it's really important, sign up for the portals, make sure you understand where all this functionality is, but it's a great way to manage how many of my claims have been received by the MCO, where are they, pending, is there, in some sort of adjudication process, whether they've been paid and how much was paid on that claim, whether they've been denied. If it was denied, why was it denied? That explanation so you can make those corrections. So I sped through that really quickly because I want to make sure that we do have some time for questions. But again, the two key takeaways, there's two, if you do have issues, it's either going to be a rejection, which means you're going to file a new claim, that they're going to tell you what was missing, it didn't pass through the screen, never got to that MCO. You just need to file a new claim. Or you can be denied, which means the claim made it through the screens, it's in the MCO system, it's been assigned a claim number, and it's been denied for payment because of some other reason. They'll provide you with what that reason is, and then you're going to submit that corrected claim to get paid. So that is Medical Billing 101 for diabetes support and management services. And I hope it wasn't too overwhelming.
Thank you, Lindsay. Rebecca, are there any questions that came up?
No, nothing came.
Someone did ask if we have questions come up after this, can we reach out? And yes, but I would say we might have limited ability to answer, but we will try. You can reach out to me. This is Jana at IPHI. I can put my email address in the inbox. And again, we are more facilitators and conveners with some connection to experts like Lindsay and others. But if you reach out to me, I'll try to connect you with the right people who can help.
Yeah, and the other thing I would say to that, Anna, and I should have said this at the very beginning, because this is a new service and a new benefit under the Medicaid program, you know, HFS is implementing it. And I think, you know, as with any new service, there's going to be things that they haven't thought about, like, oh, yeah, we hadn't really thought about that. So we may not have all the answers right away, but I think we can definitely facilitate getting them through HFS and bringing them up to HFS, just like that hospital place of service. They hadn't really thought about, I think in their minds, this was very much a community-based provider services. I don't know that, you know, the hospital thing they hadn't really thought that through. So it's good to ask the questions because sometimes they just haven't been thought of. You know, sometimes we don't know what we don't know. And so we may not have the answer right away, but we can certainly engage in some dialogue with HFS and work through it.
All right, some questions have come in. Is prior authorization required for any MCOs? Your slide for provider portal showed it was. You mentioned earlier that PA was not required.
Yeah, sorry. That is just their functionality. Prior authorization is not required. This chart just shows the functionality so that you could, if you did require a prior authorization for a service, which we do not need for these services, you can submit it through the portal as opposed to, you know, a paper fax form or something. So this is really just about functionality, not you need to do this, you need to do that. It's just showing what you as a provider can find and do on their portals. And I really just pulled it up for this, you know, the fact that you can submit your claims online or submit corrected claims, et cetera. But there is no prior authorization required. Referral from a provider, but not a prior auth. I know it seems like splitting hairs, but you do not require a prior auth in the traditional sense of a prior authorization.
And then can we back bill from 8/1/21 once we have our new NPI number?
Yes. As long as it's, you know, within 180 days of August 1st. But you still got some time on that, so, but yes.
People actually are asking about the first webinar recording as well. So when we send out the webinar recording for this webinar, we can include that as well, just so anyone who's interested. Someone is wondering the best way to inform our finance department about getting this up and running.
Boy, that's sort of a organizational specific question. I mean, there is the provider notice that HFS sent out, and I believe has been part of what you guys have posted, right, Jana?
Yeah. So
if
when
not,
I
it's definitely on the HFS website.
Mm-hmm. I can send a link to the provider notice again in this follow-up email with the recording training of how to enroll and impact and MCO rosters, this training. And then again, anyone who registers for the DPP training will send all of it again. So we'll just keep sending it. And, you know, the internal work you have to do to get the finance department to pay attention, I think you'll have to figure out on your own, but these trainings hopefully and the provider notice can help them figure out how to set these systems up.
Nothing else has come through at this point.
And if anyone's running, yeah, it looks like maybe some people are experiencing that Medicaid told them that something's not allowed. So let us, if you're experiencing anything where you think you're eligible and you're being told otherwise, let us know again, because Lindsay said we might be able to raise some of these issues up to HFS if we're hearing that there are issues across a lot of providers. All right. Lindsay, thank you so much for your time. I hope this was helpful for folks, and we look forward to the training on billing and claims for DPP on October 7th. But thanks again, and we'll follow up with an email in the next day or so. So thanks, everyone.
Have a great day, everyone.
You too. Bye-bye.